hospital only is sitting at a loss annually of about 6.6 million based on September through April. Pavilion, or your nursing home, is doing okay. They're making a margin, about 400K. IOP also making a small margin, about 280K. Your geriatric behavioral health program is losing a little bit, about 310K. But our understanding that service is essentially full. I believe there's 30 or so beds, all of them are used. So clearly there's a need for that in the community. So as we think about the hospital only area, what you'll see here, and I know this is small, so I apologize, but you'll see the first section of all of the cost centers that are included in the hospital only. And what we've done is we've taken all of the cost centers that did not have net patient revenue, and we've spread the cost over each of the other departments evenly in order to give you all an idea of what their real net operating income is. Now, this isn't perfect, and like Paul kind of alluded to, having a detailed accounting system and going through the exercise of really understanding how the allocation should work. Should, CT get 25% of the administrative cost and ER get 50% of the administrative cost, because that's the way it really works. That's work that we would recommend doing. But as we look at it evenly now, you can see here that from that $4.4 million loss that we showed you through April, your med surge, your ER, your labs, your pharmacy, your therapy, your respiratory therapy, your radiology, all of those look like significant losses for you. Our main focus as we think about this is what are the critical services to this community? What are the critical services to the things that need to stay in the industry in this community? And so obviously the ER, right? Obviously imaging, right? Lab. Those things we have to have. And then to Paul's point, pharmacy, there's a lot of opportunity there. Just with what he said, there's an $800,000 opportunity, and I think we probably softballed that in a big way, just understanding the relationship that you all have with the community pharmacies. So these are the first few, and then as we move on, we have the next set until we get to the end. And you can see here, what we did was we put the biggest revenue cost centers first, and then we moved on to the smallest revenue generating cost centers to give you an understanding of where the priorities would lie as we think about this. So, in our opinion, this is where you have a big opportunity. If you want to make an adjustment to the tune of millions of dollars, we need to make some tough decisions around what we're doing with our hospital service and what we can consolidate. If you want to make some adjustments to the tune of hundreds of thousands of dollars, we can go through the first couple of things that we spent the first hour and a half on. But I think that as you guys think about this as a community, and you think about what the subsidy need is, you have to start thinking a bit bigger and more strategic along these lines. Anything else?
Yeah, just add a couple things. So I think there is quite a bit of opportunity to make improvements based on offering everything that you're offering now. You saw that. It was like, $3.5 million or so, which is not bad, which would do pretty well. But we've heard a lot of the history here, and if you keep going like this with a very, very small inpatient census, I mean, it's very difficult to make it work. And to change that, there are a lot of inpatients here. community's big enough, the surrounding area, but they're all going to other places. And for you to change that in any amount of time that's reasonable, that's changing the perceptions of the hospital, that's changing having the providers, having the specialties, that's all expensive. That's a lot of investments. If you guys are willing to invest in a lot of money into trying to make this a full-service hospital like it is now, then great. Will you be successful? I think you got a 50-50 chance. How long will it take? It'll take a few years. Or, you could kind of do what you're doing now, really tighten down the operations, do better on the revenue cycle, crank out the retail pharmacy, start getting all those scripts from the clinics, make your clinics, get more volumes there. Maybe you could do okay. Or then the other option is what we're talking about is, so what if we didn't have inpatient services in the hospital? What if we didn't have that, all that expense for those 2 patients a day, right? You have some great hospitals, that map that Garrett showed, and all the hospitals around in Wayne County and Bacon and all this. Wayne's a beautiful campus. They're not that far away. They have a lot of inpatients there. You could get into some good relationships with, right now you send a lot of your even sicker patients that can't go to Wayne, you send them to Memorial in Savannah, where they sit in the ER for 3 days waiting for a bed. You could maybe work with St. Joe Candler or somebody. You may have to wait a little longer to send them, but when they get there, they'll have a bed for them. So you have to work these relationships with these hospitals to say, how are we going to transfer these patients that need inpatient services? And then we go back and we focus on emergency department. We have a 24/7 emergency department. We have imaging services, great imaging services that make money on the outpatient side, right? We have our labs. We have our PT and OT. Now your pharmacy, you'll probably lose your 340B status, so the pharmacy may not make a lot of sense. But but the services that the community really needs to have and send out the inpatients elsewhere and develop those relationships and have the transportation. You have a pretty big EMS service right now, as I know. At least spend a lot of money on it. So that's an option. So one of the things we looked at, and I know the hospital administration has looked at this, and maybe the hospital authority has looked at this, but going to what we call a rural emergency hospital, right, status. It's a fairly new status. We're not 100% sure you can even get it. There's a lot of issues, and we were going to walk through that. I don't know how much more time we have, but but what basically it is having a 24/7 emergency department. You would get a little extra kicker on your reimbursements. It's about a 5% kicker for the services you offer, and you get some money each month. Exactly how much, not sure. It could be a couple $100,000 a month, and then you can maybe mitigate that loss and maybe break even, or if you have a loss, it's a very small loss, something that's more palatable to to the community that has to pay for that, and you go in that direction. In order to do that, and I know I'm jumping into these slides here, but trying to move along quicker. Yeah, these are the details. We don't need that, right? Okay. So in order to do it, basically what this is not having your inpatient services, but having all the outpatient services in a 24/7 emergency department. This is a fairly new program. It's been around since about 2022. There's 2 of these in Georgia right now. I think I heard one of them is trying to switch back to critical access or something. It would have been great if you could have been a critical access hospital, but you missed that boat a long time ago, and there's no going back, at least right now, unless Congress does something. I think you missed that boat in 2006 or so. So no chance of being a critical access hospital right now. So this could be an opportunity. Now, there are some issues. So you guys, there's one issue that we were surprised. We thought you had less than 50 certified beds. When we looked you up in government sources, it had you at 49 certified Medicare beds. We have heard recently that it's actually, 65? 64? Okay. 64 beds. I'm not sure when that happened. The data we got was from the cost reports. Well, there is a rule that you can't have more than 50 beds as of 2022, was it? Or 2020? Yeah, it was as of 2020. You had to have fewer than 50 beds. Well, I guess the state data says you have 64. I don't know. There's something we'd have to do some more work into looking at if you could do this and if you could meet. I think most of the other requirements you could meet, and this could be an option for you. Like I said, the reimbursement, you get a 5% kicker. You get some money each month. Also on top of that, you would lose your 340B status. There's some questions about if you can have behavioral health. There's questions about what do you do with your pavilion, which is your nursing home. What do you do with that? What do you do with your GBH program? There's a lot of questions that need to be answered, but it's something to look into that could be a better long-term sustainable option. We're not saying you got to go out and do this, but we're really recommending you dive into this because it could be good. It could be something that you could do. So I know that the hospital administrators know a lot about this. I think the commissioners know about it, and probably the authority have heard about this program. And we would really encourage you to dig into that to see if that's an opportunity. It'd be a big change for the community in a way, but I think it's more perception because you only have a daily census of 2, right? And you're paying a lot of money to have those 2 patients.
Let me ask you a question. On slide 33, it had the admissions at 2.5. So what was the actual daily census?
Slide what?
Slide 33.
Okay, let's see.
And is that averaging in our geriatric beds too, our GDH beds?
I think if you include, I think your pavilion is what, 86, I think? Is around 86 is your census? Oh yeah, the geriatric site, yeah, is 30, that's pretty full.
Yeah, but it's here it was 2.5.
That's your acute care.
Admitted,
Yep.
so not the census.
That's your acute care inpatient, not nursing home
But the
or,
number admitted, not the daily census, right?
that is your, yeah, that sounds like your daily census. Yeah. I can answer that in a second if I could get off Teams and open up my computer, but I think it's actually probably a little less than 2.5. If you were admitting 2.5 patients a day, your census would probably be around 6, right? Because the average length of stay is about 5. So there's no way you're admitting 2.5 patients a day. Now, some of those could be observation patients, so they're not really admitted, but they could be in a bed, but that's not right. I think what this is saying is that, I'm not exactly sure what it's saying, but it's saying those are how many patients the hospitalist is having to see a day, I think. Okay. But, I mean, the question, I mean, where's the, this is the issue is, I'm just, okay. Well, annualized, but I know it's a little better than this right now. Let's just go to the actual for through April, Now, the cost accounting, like Garrett said, isn't great because you have a cost accounting system, but you could, have somebody spend a few weeks and dig into this and do a manual cost accounting on a spreadsheet and really dive into it. But this is right from how you have it right now, with the hospital at a 3.7 million loss. And well, that's not just inpatient. You got other departments in there that serve outpatients. So that's why that's why we tried to tease it out in our back of the napkin cost accounting here, where we looked at allocating the other expenses and the deductions, revenue deductions, and say, okay, what would all of these look like, Again, the cost accounting is not perfect. It's the back of the napkin. But you can see the med surge there with the big loss. Some of the stuff is a little surprising because I don't think we spread out the deductions from revenue based on the percent of the gross revenue of that cost center, that department over the all. It's just not the exact way to do it, right? Same with the administrative cost, but it's what you do if you don't have a cost accounting system. But it kind of gives you an idea. And then here's the other departments, so. So anyways, and there's other things. It doesn't have to be, if you can't get the REH designation, you can still do things where you can be more of an outpatient facing facility. I mean, your clinics are underutilized. I think you saw that. I mean, you only have a couple providers in the primary care, a couple in peds, right? Which, they're not, there's a lot of opportunity there. If you keep inpatient, you can keep your 340B. So there's an opportunity there to really, I mean, that should be doing a lot more. And maybe it's improved since the data that we got, but you should be able to make a lot of money on that retail if you're really maximizing that 340B opportunity and capturing those scripts. So I know I sped through that pretty quick, but we were getting a little short on time. Let's see. There were a few questions that people had. Yeah, we kind of already answered these. Behavioral health is going to be a question. 340B, but the 340B based on your current benefit isn't that much. Now your possible benefit that you could be achieving from 340B is a lot, right? But your current is only, I don't know, $160,000 or something. It's just nothing. So you're not actually giving up a lot right now. Losing that, you're giving up the future value of what you may be able to do. And I think that is it. So what we would suggest is kind of the next steps is to, and you probably want to do this anyhow, because if you're going to make this conversion, it's going to take a while, right? So don't slow down on this stuff that we pointed out on this performance improvement. Get after that revenue cycle opportunity. And that is, just money you're leaving on the table. You're doing the work, but you're not getting paid for. So, plug all those holes so you're getting all that revenue. The labor.
If try to stay a full hospital like operating her, how many years do you think it would take, best effort, to get it up to where it would work?
Where it would work? Well, definition of work.
Where it would hold its own.
Break even. I don't know if you'll ever necessarily be, there'll always probably have to be some subsidy.
How many? So you don't have a time frame with current ways to operate current, how long it would take?
So you can improve operations by $3.5 million, right? Now, last year, I think you only lost $2.5 million, I think, or 2.7. 2023, where'd Robin go? Okay.
It's about 2.5.
There you go, about 2.5. This year, you're on track for maybe 4.4.
4.4, but we've had a lot of changes this year, which has
Here-
expenses that you're seeing.
Here's where I'm getting to. How many millions of dollars would we have to subsidize to get it up to where it's just a barely loss then?
All right, so if you say you could implement these opportunities that we laid out and you could do a $3.5 million improvement. So if you guys were only losing, say, off of operations, $1 million a year, 750, you could probably get there if you go all out. And like the
How much
labor-
would it take to get there, though, is what I want to know.
Yeah, well, money to spend to get there? Mm-hmm. Not much. I mean, you guys have already, it's more just the willpower to do it. Like the labor opportunities. It doesn't cost anything to do the labor. It takes some courage, it takes some willpower, it's people's jobs, it's getting people to work more efficiently. It doesn't cost you anything. The revenue cycle improvements, not going to cost you anything. It's just doing it better. You've already invested in a new upgrade to Meditac, Expanse. I'm assuming that's paid for. So I don't think there is. Now, but it's going to take you, maybe this answers your question better. It's going to take you 9 months to implement everything. The pharmacy will probably take longer, but 9 months. So you're going to have to continue to subsidize for a while until you get those improvements done.
Yeah, well, I'm still not, based on your numbers, I said, I believe said lost 2 million last year, losing 4 million this year.
Yeah.
Based on your numbers, how many millions would it take to save the hospital?
But that's kind of a hard question to answer. I think it's how long would you be willing to suffer these losses before you can stabilize it is the question. So say 4 million.
Yeah, that's not a good question for the commissioner. That'd be a question for the hospital board. But we got 2 options here: to invest a lot of capital where we're at, or go to a rural emergency health care,
If you can do it.
which is the most recommended on your part. Is that what I'm hearing?
If you can do it, I would think that would be a very good option. A very good option to look at.
Okay.
Because you're spending a lot of money to try to maintain a acute care inpatient hospital.
Well, yeah.
You know.
I have a question. This is Andrea. Can you hear me?
Yes.
Okay. So, I guess to maybe try to piggyback on what Randy is saying is that the hospital itself right now has asked for $3.5 million based on what we have seen from what our bottom line improvement plan is that we currently have. If we take the things that you all have stated, for also to add into that bottom line improvement plan, we see that there will be some improvements that are made. So the initial, I guess the question is our ask for this 3.5, based on us being able to maybe see $1 million in an improvement, could that be a break even until we can keep moving forward with these plans? So substitute for the next year is absolutely something that is not feasible for us to avoid.
Well, no matter what direction you go in, none of this is going to be overnight. You guys are in a tough spot. I mean, I'm not going to lie that. I'm not going to sugarcoat that, because even if you could do these switch to an REH, you're not going to do that overnight. And you're losing money every day.
Right.
Some of this stuff you could do fairly quickly, and that's what I was saying. Don't slow down on that. But you can't snap your fingers and get out of this situation. I mean, there's obviously, now we did not dig into your balance sheet and look at your debt structure. And I understand your debt is with a private bank, private placement? Okay. That's another thing that needs to be considered. What's secured? What is securing that debt? Is it the hospital? Is it the pavilion? Is it everything? All the above. All the above. That's another complicating factor. So you're in a very difficult situation that you're not going to be able to get out of real quick. And
Well, what we do know is we can't keep doing the same thing.
can't keep doing the same thing. These things listed out here, I mean, I would personally, the biggest bang for the buck that you can do the quickest is the labor. That is what you can do the quickest. It's the least fun, but it's the quickest impact. And you could probably even do better than that we put up there. We put a pretty low number. That will really help the expenses, and you can do it quick. The revenue cycle is a little more methodical.
Let me ask you this, in some of the things that you've found as you've done this study, I know management has already taken steps before y'all come in to start combating some of this. Can you kind of speak to that? Because a lot of the things that we've done, I don't think has had a chance to be realized. Do you think what we've done, we're moving in the right direction? Do you see improvements that have been made or recently been made that is getting us where you indicate we should be?
Well, we had I believe it's called, I forget the name of the report, but it was a improvement plan, a bunch of, I don't want to get the clients mixed up. Was this the blip or the BLI? Yeah. Okay. The blip plan. There's a lot of things on there, but there's things that have been on there a long time, that had been on there quite a long time. And I'm like, well, you know, if it wasn't done then, why isn't it done now? Is it gonna get done? And then you just have to look at the trending. Are we getting there? Just having, you know, stuff on a piece of paper that we're gonna do X, Y, and Z, you know? You know, there needs to be more detailed plans. So how are we gonna do this initiative? What are the steps? What are the dates? You know, who's responsible? I did not see that all in there. I saw initiatives, and I saw dates, and I saw dollar amounts. I mean, if you're making improvements, I don't know. We did a baseline based on, like we told you, for September to March and September to April. We updated it, and we looked at your actual performance during that time. You know, the labor, we did a full 26 pay periods, but the rest were that, and we looked at that. So, you know, I can't really comment on, you know, what initiatives you're working on. Everybody's always, you know, you got to have some initiatives.
For example, like the things that we're doing with the pharmacy.
Yep.
You commented to that. And then the things that we've done for the financial assistance. We've had someone in that position. We've increased the FTE in that position. So I think a lot of the things that you pointed out, you know, we have been doing. It just, like you said, it takes time.
It takes time. Yeah, it takes time. Yeah.
I have a question for you. Over the losses of the last 2 years, do you realize or know how much was attributable to the Meditech computer upgrades? That's probably a one-time expense that won't be realized in the future.
We have that number. I don't know, did you capitalize that expense? I don't know where Robin went, or not.
Yeah, you know how that was handled,
Oh,
Robin?
Yeah,
So it may have only affected cash flow and not revenue. Okay.
my colleague said 1.4 million. Does that sound right?
1.4.
1.4 million?
I think it was closer to like 2.1, 2.2.
It always ends up more than what you think. And it always takes longer than you think.
That's been a process of how long?
About a year now.
Year now.
June 1st.
No, I mean, how long did it take us to implement it? We started spending money on it for a year.
For a year.
Do you think that will help us capture any additional revenue?
Yeah, I think you heard in the revenue cycle presentation, it was kind of hard to hear. It was a little clunky when we were doing that piece. But yeah, I think the, you know, having Expanse will help you a lot better with having the data for sure. You know, you have to have all the processes to go along with it, but it's hard to do that when you don't have the data and it's really clunky and you're trying to pull information all over the place. So it should help, you know, a lot.
I think I have that information right here, based on the February 27th letter. It was spent $826,000 thus far, and then expect additional cost of 1.3 for a combined 2.2 million.
There you go. That's the implemented.
That's implemented.
No.
How long would it take to, before time you pay for your investment, for it to start showing profit on that?
Well, it's how you use it, you know, so, you know, if you put in the new Meditech Expanse and it's up and running, it depends how you use it. Do you use it to do all those things that are on there to get them done, you know, or you just have a new expensive, you know, program and you're doing that. We've seen that, you know, people spend a lot of money to implement something and they implement it around their old broken processes. So now you just have a more expensive, you know, IT system doing the same crappy stuff. You know, that happens. You want it to, when you implement these things, you want to change your processes as you're implementing them to gain that benefit. And you know, I've seen it happen both ways.
So since we've implemented, and if I can speak, since we've implemented in June, we've been able to bill out more than we ever have. For June, we were able to collect, our goal was to be about 2 million. This is just something personal cash, 2 million. We were able to bring in 2.8 million. For the month of July, we're looking at billed out 4.7 million. So we're already seeing the benefits of the new system and being able to capture the charges that we need to.
Have you seen an increase in the revenue off of the billing cycles?
Since we started in June, we're now starting to see the revenue come in because of how long it takes to get reimbursed. So we are just now seeing that. Yes, sir.
Noticed that on some of the slides that the accuracy was of coding and that kind of stuff was an issue. Is that being resolved by this new program too?
So yes, sir, that it does
Good.
help with the coding. We also added some new coders in, so we've been able to see some difference there.
Different personnel.
Yes, sir.
Okay.
Paul, is this a problem that's unique to us, or is it, you see this kind of thing all over the country?
Yeah.
With small hospitals like
It's
us.
unique to rural hospitals are struggling all over the country. You can see that everywhere. Hospitals in general, are struggling. We typically don't work with, average hospital is not this size of hospital, We do occasionally work with, smaller rural hospitals, but you just need to read any industry, publication about healthcare. Rural healthcare is struggling, and this REH was a way to try to help them that they came up with a few years ago. It's one of those opportunities. They're talking about tweaking it and allowing like behavioral health and some other things, so to make it more feasible, but it's not a silver bullet, but it's tough to make it as a rural, unless, the critical access status is extremely helpful, right? Because you're getting cost plus reimbursement, right? That's wonderful. But since that's not an option, having a rural hospital like this size, that's not critical access. That's kind of a unique situation that's difficult to make it work.
For us to be approved, is that something that's done in the state, is that federal level?
REH is federal, correct? Yeah, it's federal, but I think you may have to apply through the state. Well, yeah. Stephen, are you still on?
Yeah, it's a federal program, so you have to apply through the federal government.
Do we know about how long it takes?
Of all the research that we've done, there was never a timeline that was provided. I'm sure it varies by geography and by organization, but I'm sure it's something that we can do some due diligence and we can probably call around.
Yeah. The bigger issue is this bed issue.
Right.
I think that's the biggest thing having 64 beds, you can't, on the surface you don't, but I was just shocked that cost reports show you have 49 beds. I saw the state documents that were sent to me and it says 64 beds, and it shows when you applied for them, and it was before 2020.
I think a big issue we're going to be our geriatric psych bed with such a need for that in the state.
Yep. Now you could, while you can't have psych, you could spin it off, right? So there's things you could do to still have the service. It would just be a separate entity. Or you could sell your services, like we're talking about the debt. Someone may be interested in that, in the pavilion, The pavilion about breaks even. Maybe managed a little better, can make money. There's some big companies out there that run these places all over the country. You could look at maybe selling some of these assets, right? Paying off the debt and then focusing on the services that you really need to deliver to your community. So that might be, and it might be attractive, because it's not a loser.
So you wouldn't look at that as a way to subsidize the services that we do need to provide our community, but we will always get money on?
Well, I think more what I was getting at is the debt structure. If you're going to if you're going to go to this REH status, right, you need to look at your debt structure and so maybe paying off your debt by, selling the pavilion, could be an option. I don't know if you could do it. I don't know what you could get for it. I do know it's a pretty big facility. It keeps it's at about 86, which is, which is a good size, and it doesn't lose much money. Pretty much break even.
More rural communities are not going to a REH model, the ones that are qualified.
The ones that aren't well, first of all, you got, if you're critical access, you'd rather be that, right? I think it's a fairly new model. I do think it would be a good idea to reach out to, I think it's Blue Ridge and then Irwin County are the other two REHs. I'd talk to them. And I think one of them I heard was trying to switch back.
Yeah, I heard they were trying to switch back.
Switch back to, were they critical access before? So can they go back to?
They can't go back.
They can't go back to,
Yeah.
see, I would.
They go in and come back out.
And I think that was Irwin, I forget which one.
Irwin, that's so silly.
Okay, so yeah, I would, if I had critical access status, I'd keep that forever, right? So I could see why they would want to do that. The other one probably was not critical access, so they can't do that.
What are the impediments of returning to critical access?
Well, you can't get it. There was a window back in, I don't know, 20 years ago or 18 years ago. Yeah, in 2007, yeah, quite a while ago where you could have done it, but that window closed a long time ago. So you have to have, there's two issues, the number of beds. I think you have to have less than 25 beds or 25 or less. And the other thing is there's a distance thing to the other hospitals or another critical access hospital or to the other hospitals. So you don't meet that requirement, but there was a little waiver period that was out there. Now there's talk and legislation about opening it up again, but everything's talk in the Congress. There's so many things. They talked about 340B and killing that for years, and that never changes. So I wouldn't bank on that coming back.
Also, I understand there's advantages also to not being a critical access as well. Is there opportunity for us to work with the other critical access hospitals around us to provide some of the services that they cannot?
I mean, possible, but they're not going to want to give you any services that make them money.
But if they're bound by their length of stay.
Oh, you mean they can't take any more patients, kind of thing? Yeah, but I doubt that typically happens because 25 bed, most critical access hospitals aren't running a census anything near 25, right? So they kind of have the capacity, I think, for the most part. But I don't know that for a fact for here, but I'm sure they'd be more than happy to send you their uninsured patients. Yeah, here you go. Take these patients.
I have a question. Whenever I think of business development or getting out of the hole and basically thinking about the money, I'm like, okay, so what are we going to do next year so that this doesn't happen again? And with everything that you said, I hear work smarter, work harder, more efficient. Are we losing revenue because we didn't get authorizations in time? Is it something that we could have organized better? But the main thing is business development or volume. I'm concerned about the med-surg floor closing because of diversion status. Our ER predominantly sends to Memorial. They could send to the others as well. But I guess my point is that if we closed our med-surg, it could be catastrophic for us. Because if they're on diversion and they can't accept our patients, at least we can admit them to the hospital and maintain their lives or what have you until that bed become available. So by cutting out med-surg, it would bombard our ER. Because if they're on diversion, they're on diversion. So that would just swamp our ER with people who were not able to go home.
Maybe, but I think that would be very rare. I think you could work with, I think Wayne would be really work with you for those patients that they can't take some of the the heavier ones.
Most of ours that go out usually fly to Savannah because it's usually they need a cabbage or they need park cats or something more extensive. But if I were thinking, and I was gonna ask you your expert opinion, when I hear of, the inpatients and stuff, my idea would be to increase the volume. So if the pavilion is our cash cow, why would we not go ahead and fill it up to the 100 more beds, or maybe even get a CO in for 25 more beds to offset the cost? Because I came from Liberty County, and our postal man are actually made payroll. The long-term care facility carried the hospital for that very reason. And they expanded their beds and so forth, which we know makes money. But I guess the other thing would be we have probably 8 or 10 mid-levels in town, and like you said, they're using other facilities, and we only have 2 doctors. So would it be beneficial for us to maybe work with a J1 visa, getting some of these doctors in here from somewhere else to bring us more volume, which would in turn order more X-rays, more CTs, more MRIs?
Well, there are a few questions. I think the one with the pavilion, the issue is, yeah, you can get more patients in there, but getting patients that are insured, that's the problem. Because I tell you can fill that thing up, but then they're actually doing a good job of being selective right now on making sure you're bringing in patients where there's a payment source, And then the other thing with trying to get the growth, it's possible, but that's a lot of investments. And that's why I said you could invest and try to get the growth and bring in the doctors. And I think you have maybe Dr. Carter that may be sending stuff here again or whatever. But that's kind of a...
Well, I was just saying partnership with a major $1 million or $1 billion company to bring physicians on, which would in turn, they would sign a contract with us to bring these doctors on to admit to our hospital, which in turn, if they needed other resources, such as cardiology, whatever, they would refer back to themselves, which is the idea behind it.
Yeah, I mean...
Paul, I think that, this is Andrea again, I'm sorry, I think the overall take from all of this is that you guys are presenting information that is relevant, that we can make improvements on, but ultimately it's Akron County's choice if we make this investment in our organization and we make it look like we want it to look. And this is all strategy that comes after your report.
Yes, exactly. No, that's exactly right. And I've just seen I was on a call with the COO at a huge New York City hospital yesterday. And she called it the volume ferry. Is always, it sounds great. I get this volume of all these great ideas. How often does that volume actually come, and how long will it take to get here? And it also takes changing perceptions of the hospital and all these things. And it's kind of a little bit of a pipe dream that, okay, I'm going to go after this, I'm going to do all these things. Okay, 2 years from now, we're sitting here having this conversation again. It'd be great, but I wouldn't count on it. I mean, it's hard to do. Volume's the hardest thing to increase volume, especially when you're restricted by number of providers.
When we started these conversations, when I started in this role, and then as we continue to, increase awareness, is that it is us working together. It's us working together to show what this organization needs to look like from our community standpoint.
Yeah, and I think you guys, you have a lot of smart people on the board, on the in the executive team that, you guys can dig into this stuff and say, okay, let's really dig into this REH and see if it's something we can even do, right? We have a few questions we got to get answered. If this is a direction that we can do, right? But in the meantime, let's not slow down on this stuff. Some of these things might already be on your plan, and you're already working on some of these things, and that's great. But double down on this, so you can get some immediate relief from the financial situation.
Robin, what's our census today? 8. How about behavioral health? 23. Good. So those numbers are quite a bit better than...
Are they all 8 inpatients that they've been actually admitted, or?
5 inpatients, 3 observations.
Okay, 3 observations. 5's good, though.
It has increased.
Yeah, that's great.
The data that you've received.
Yeah, no, 5 is great. I mean, that's
So what do you got any idea what it would take on an average to turn our numbers around?
Probably, I mean, what you could do and what we could do is just look at a sensitivity analysis, right? What would your inpatient volume need to be at, right? And taking into account making some of these improvements, where would that be? We could aim towards break even, but I think you guys would probably be like thrilled if you could maybe just lose $1 million a year and no less on a consistent basis, maybe, or $500,000 a year and no less on a consistent basis. I mean, you're already giving quite a bit of money, right? The county is, between the EMS and the and various hospital asks. So we could do some sensitivity analysis to say what would that inpatient volume need to be at in order to and bake in, including some of these, where would you need to be at? Because I did hear one of your providers, Clay, is going to maybe be admitting more patients down here or something. I don't know. So I don't know if there's. You got to get doctors that want to admit patients here, and if they come to the ED, you got to, and they need to be admitted. Go get them there whenever you can. Because I think your average daily census was around 2, if you looked at the last 2.5, maybe, when we got the data for the last year. And that's true inpatient, not observation patients.
On the data, you had 2 Dr. Orlando, basically in Appin Ped. We have several other commissioners that have to operate under a doctor. They can't operate on their. I mean, they can't have their organizations on their own. How do we get those to have those doctors that are supervising the nurse practitioners to participate with us as far as the hospital is concerned?
The ones that aren't part of your
organization.
So there's like, what, 8 to 10 nurse practitioners?
There are 16 other providers in town that are not employed by African Healthcare.
Are they all mid-levels?
14 of the 16.
That's what I heard. I heard all of them were, but I guess maybe there's a couple of doctors. And I don't understand that, why they're all just hanging their own shingles, right? None of them are associated with you. I don't know. But does a nurse practitioner have to have I don't think they have to have a.
We have to have an elevated position in the state of Georgia. We do not have a position in our office, and we are allowed to own our own practices.
Yes. You must be one of them.
And
okay.
In one position can supervise 4 primary and 4 secondary.
There you go. So, I guess your question is why?
Well, I mean, the nurse practitioners do not have admission responsibilities or abilities.
Our patients are admitted, yes, sir, we do.
And that's part of that's what I've heard, and this is all just, from talking to people, that there has been and that's kind of the reputational issue. We've heard there's been a little residency to admit patients at Appling, and they get sent out, and you saw that on the charts, to the surrounding hospitals. Why that is, I don't know. But it's hard to change that, those referral patterns.
That is an important question.
Yeah.
To get to the bottom of that, and why is that? Not how to force nurse practitioners to work with a hospital. Why is it that they're not?
I've heard stories and examples of stuff, but, nothing I can verify. But changing those referral patterns is very difficult. And people have long-term memories. They may remember something happened, 10 years ago to one of their patients, and they're like, I'm never going to send a patient there again. I've seen it, I'm not talking about here, but I've seen it at all kinds of places.
Relationships is part of that.
That's what it's all about.
Hospital our size, the management staff, executive management, what to the hospital our side, we're not growing right at the moment, that's for sure. What staff or what position should be staffed for hospital our size?
At that top, like executive, like if you go back to the span of control? Yeah.
CFO.
Yeah, typically you would see, of course, you always have a CEO, unless it's part of a bigger system and it's a smaller hospital, bigger system, they would just have like a site administrator, right? But you're standalone, so you'd have to have a CEO and a CFO. And then, that's pretty much at the executive level. And then below that, you would have, directors or managers, whatever you want to call those titles, but reporting up to probably just what we would technically call an executive. Your situation's a little different because the pavilion's a big operation, whether you have an executive or that, or a director or something like that, but typical CEO, CFO.
Any other questions? Mr. Paul, we appreciate it.
Thank you.
That question, just for the audience there, is that we have a CEO, we have a CNO, which is a Chief Nursing Officer, and then Robin actually was functioning as our CFO, which is now in a CFO training role that has a mentor. So currently, our organization only has, in the executive positions, a CEO, a CFO in training with a mentor, and then a Chief Nursing Officer. So I don't know if that's a misconception for everybody, but that's our model.
Are we paying the mentor?
He does invoice for hours or minutes that we talk. It's not a flat rate. It's just
I
how
saw
much we
$135,000 on something other than, I guess,
No,
for the year.
His fee per month is probably, I think the last month, the invoice we just got was around $1,200.
I think what you was talking about was the guy in Tennessee, the billing department in Tennessee that does the financial right now. That was probably that amount you was talking about.
That's what she just said was $1,200.
Okay, so we're not utilizing their services anymore for billing and payroll?
I think that's different. I think you're talking about the HR, I don't know. But,
okay, I thought we had a contract CFO is what I understood.
is our interim who is training me, but like I said, he only bills us for minutes or hours that we talk, and he reviews our financials with me.
Okay, I misunderstood that.
he's in Tennessee.
He came on as our interim CFO, back, when John Graham transitioned out of Allen Healthcare. We brought, Ray Ledbetter here for a period of time. When he transitioned out, then, Richard came on with us, and stayed with us, and I can't remember if it was 6 months. You probably have to help me with that, but, then we had a different model, and then when his contract, was ended, we moved to this model, and so we've had very, very little expense with the mentor program, that we've worked with Richard.
We appreciate you coming and talking to us tonight. Thank you, sir.
Thank you.
I hope that, all of us working together, it will help us.
Absolutely. Well, thanks for having us. Appreciate it. We'll do follow-up. If there's any follow-up questions, we're more than happy to, or information to get that to you. And we'll get the report over to you, Allison. I do need to fix that one. The one, somebody pointed out one of the numbers. Yeah. 35 should be 50. Fix that first. Well, thank you, everybody. Appreciate it.
Young man,
Nothing to report, sir.
everybody, the participation, the work, the audience, the interest. Thank you all.